We're going to go ahead and get started as people trickle in. My name's Dan Wieberg. I am the Senior Director for Innovation and Leadership at Kaiser Permanente out in the Bay Area. I work at our program office leading technology stuff, and we're building a new medical school, and I get to be a part of that. But today I'm going to play the role as moderator for a panel where we're going to talk about how a patient might experience telehealth, how physicians and clinicians and nurses might experience telehealth in a futuristic, technology-enabled way. So we hope to make this very interactive. We'll be showing some videos, some provocations of the future, which may seem very real now. These are some videos we created a few years ago at Kaiser Permanente because we had trouble convincing executives that healthcare was going to be enabled by technology. So we hired some actors, we put some videos together and created a patient and provider journey. So we'll use those videos as provocation. And we want it to be very interactive, so we'd like you to use the app, we'd like you to come up to the podium. We'll do some audience questions throughout as we have the provocations, and we'll go from there. We'll hope to have a great conversation. So the bios are in your app, so we won't read the bios, but I'd like to introduce you to our panelists here. Dr. Robin Felder is an amazing researcher who's done a ton of work in IoT and wearables and all kinds of different things. And Dr. Raphael Grossman is famous for being the first surgeon to use Google Glass in the operating room. So I'll let them tell them a little bit more about their roles and things. And as you guys introduce yourselves, I'd love to know what your superpower might be. So Robin, go ahead.
Well, my superpower is avoiding administrators, and it's treated me very well all these years. But just basically, I started out as a basic biomedical researcher, grounded in biochemistry, and then realized that there was a lot of things we couldn't do because we didn't have an engineering group. So I built up a whole engineering group. Now it's a continuum from deep dive biochemistry through clinical trials, through engineering, and we design technologies, which I'll describe today as it comes up in the discussion.
Raphael.
Hello, my name is Raphael Grossman, as you heard, and I'm a surgeon, a full-time surgeon, and I envision the world as a place where technology can be used in a smart way to improve what we do, especially in healthcare and education. I think that technology has been for too long misused and cut really for what it could be in helping us do our work better. And especially, I'm very passionate about thinking about technology as a tool to make us more humane in the way we practice healthcare and in the way we educate the next generations.
Great, so you heard some things there. So we want you to challenge us as well. We'd like this to be a provocative conversation, so push the walls on compassion and technology and some other things as we go along. So just to warm us up, I'd love to hear your thoughts each on what the most innovative technology you think is out there right now. As far as healthcare, wearables, IoT, something that's advancing health, what's the most innovative thing?
Well, I recently came across a ring, which I'm wearing today, and what that's giving me is full of systolic and diastolic blood pressure, perfusion, breathing, blood oxygenation, a single lead electrocardiogram, all that's happening in real time. I get about 19,000 data points a day. It all gets aggregated. And what I'm using it for, and we'll probably get into this a little bit later, is the fact that 50% of this room is going to have or has hypertension and or salt sensitivity. You can have perfectly normal blood pressure, but still be salt sensitive, which is going to reduce your lifespan by 20 years. This ring can measure your blood pressure at night, watch it dip by 10%, and if you aren't dipping, you're what I call flatlining, and you know what flatlining means. You're going to die. So it's essentially a way of forecasting your cardiovascular health and giving you a daily nudge in the right direction.
Right. Raphael, what do you think is most innovative?
It's a difficult question because there's so many gadgets out there. You see a ring. I have a ring that is also basically the Aura ring, which I've had for almost a couple of years. It does everything that a Fitbit would do. And the Apple Watch, I think, is an amazing device in the ways that gets data points that that could be very helpful in helping you prevent a disease or even regaining your health if you lose it. I've had the Omron blood pressure watch, which is also a wearable blood pressure monitor out there. It's the first one of its kind, and I've been trying it for a few months, and it's kind of an interesting device. But for me, you know, I like to keep it kind of simple, and I really think that out there today, and really for the last 8 years, we have the ability to do portable video conferencing. And to me, it's a little sad that in the year 2019, we're not using a technology that allows you, let's think FaceTime or Skype or any of the other video conferencing platforms out there that are completely portable, almost a Dick Tracy style, if you remember the phone on the watch. And we're not using that to potentiate, to augment the way we do healthcare. And that's a simple technology out there created for something completely different that allows us to empower our connection and our connectivity. And I think that in healthcare, that's what we have lost, and that's what we have to create. There are a million other devices and wearables that are phenomenal today and will be even more phenomenal because technology develops exponentially in the next few months. But I think that keeping it simple sometimes is just a matter of how do we use technology that we already have in a way that can augment what we do.
Great. So one of the things that we wanted to do today is put you into the shoes of a patient so that we can make this real and actually have some conversation with how a patient might see some of these things. So I'm going to introduce you to Leo, and we'll see a video in a second. So Leo is a 68-year-old man who's on Medicare, and he has congestive heart failure. He has some early memory declines, and he's married to his wife, Rosemary, and he has a daughter who lives in Portland. Leo lives in San Francisco. So Leo and his wife had breakfast this morning, and they're out for a walk. Leo has a wearable technology that is monitoring his vital signs, and he gets a call from an automated system that has found an alert with his vital signs being out of norm. So if we could play the video, we'll pick up the story right about there.
Hello?
Hi, this is Joe. I'm a KP avatar. From the readings on Leo's bracelet, we've noticed that he's having some trouble breathing.
Well, we just had a heavy breakfast and we took a long walk to the hardware store. So he probably just had too much to eat.
It might be nothing at all, but we'd like to take a closer look at him. I've located a Medicar nearby.
I'm fine, Rosemary.
I know you are, but why don't we just let him take a quick look?
Great. It will be there in less than a minute.
Okay, thank you. Thank you. Feeling all right?
How are you feeling?
I'm fine.
I noticed that you have some difficulty breathing. Do you have any shortness of breath? Any pain?
I said I'm fine. I just ate too much.
Okay, well, let's do a few tests to make sure. Put your finger on the pad so that we can get a pulse oximetry reading. And I'd like to run a quick blood test. Please put your finger in the small compartment on your right. I'd like to bring in a physician and your navigator right now to review the results with you.
Okay, so Leo had some vital sign changes. Instead of calling in emergency services, they had a driverless car, which was also a telehealth vehicle, show up at his location. He gets in, he does some further diagnostics in the car, and then they're going to patch in the emergency physician through video. The story goes on to where Leo actually gets diagnosed because there's an ultrasound in the car, and they does an ultrasound of his lungs, finds some fluid, and they drive him to the pharmacy. He gets his Lasix, and he goes home with home monitoring. So he never touches a facility. So my question to you both is, how far from reality do you think that video is? How many years out?
Oh, I think that there's an awful lot of examples of that reality being in place already. About a decade ago, we produced these sensors that were passive in elder care facilities, and we could monitor during, especially sleep, all of the vitals, and we had blood pressure teed up. We could measure socialization, nutrition, bathing, gait. If you'd had a hip replacement, you could see if you were on a normal healing curve or it was delayed, because that's a fairly protracted healing process. And so I think there are about 6,000 of those systems now installed across the country. So there are examples, it doesn't come up on the evening news all the time. So the question is, okay, what's the layer after that? And I think certainly the delivery of healthcare into the home. The home is the health center. Unfortunately, architecturally, there isn't really a place you say, I'm going to go into this room and be healthy or be monitored for health. And so it becomes your bathroom or your bedroom, and those are spaces that have other connotations. Probably the morphing bathroom will become your health center, and you'll rarely see a physician or a hospital unless they need to do some cutting. And I haven't quite forecasted where that's going.
No, I agree 100%. This is already being done in not just the US, in many places, in the Nordic countries, in the Netherlands, in the UK, Babylon Health. That's a concept. Use the technology that we already have to get the patient away from the actual brick and mortar facility, from the hospitals. Even, in this case, we have a driverless car that comes in with all the gadgets and all the, like Robin was saying, the care at home or whatever you are, where you can get all the monitoring in a completely mobile fashion. That's available. But like he said, the next layer. So who's gonna pay for that? And that's where the problem lies. I think that and the regulation, the regulatory, details, that's really what's keeping us from having this available currently.
I thank you for teeing up who's going to pay for the bill on this thing. We did a case-controlled study in Sioux Falls, South Dakota, where we were monitoring elders from Charlottesville, Virginia, so that's a bit of a stretch. And so in the course of several months, we saved their systems 50% of the cost of caring for those elders. And everybody says, how can you save 50% off the cost of caring for elders? Well, for instance, if there were increased bathroom visits during the night, that was about 98% correlated with urinary tract infections, which are common in elder care facilities. And so the usual dogma is that patient has to be taken by some kind of transport to the hospital to deal with something as common as a urinary tract infection. If we did early forecasting of it, then a signal went to the kitchen to push cranberry juice and all sorts of acidic drinks. And so we eliminated urinary tract infections during the course of these studies. So sometimes it's the simple things, and so the returns are enormous. And that's what I think we haven't quite realized yet, because very few people are doing case control studies to demonstrate that dollar savings as well as health improvement.
And it takes a vision, because the thing is that you see a lot of healthcare systems that don't have the vision. You just focus, how much is that monitor going to be? How much is that wearable going to be? How much is that car going to be? But then, if you don't look past, that and have the vision of how healthcare could be, and then get validation with studies like this and others, many others that are there all over the world that show that this is the way to go. And in the long run, you save money, but most importantly, you improve the outcomes.
So one of the things when I've shown this video to inside, outside Kaiser, tons of people, and one of the big pushbacks is the risk. So I would never send a CHF patient home on home monitoring. We never practice like that. This person has to be admitted for 2 days. So, and a lot of it's from nurses and physicians who have practiced in the system as they know it. Do you have advice or thoughts on how to overcome those barriers?
I think it's just education, really nothing. If you think about patients who have their gallbladder removed and go home a few hours later, versus when I trained, even in the early 90s, patients would get an open cholecystectomy and they'll stay in the hospital for 5-7 days. Compare that, a carotid endarterectomy, a AAA repair, things that we would not even dream or have the nightmare of a patient going home. And now, so it's really education. There's no other way of doing it, I think.
Outcomes are often better at home because that's their natural environment. The trouble is that a lot of single people that go home don't adopt proper nutrition. So what we aren't doing is following them home and monitoring them in situ to see if they are maintaining proper health initiatives to get over their issue. And so the readmission rate, that's why the feds have said, we're going to go after the readmission rate and not reimburse you for that because you're not taking care of the whole problem. You're doing this and then get out of my face and then on to the next one. So I think there's a golden opportunity with that sort of embedded sensing. We could do assessments of nutrition by measuring how long somebody was preparing a meal. All the cabinets were monitored just on-off, where they opened or closed, and the refrigerator. If you're opening and closing the refrigerator far more than your pasta cabinet or your cookie cabinet, then you can see the balance of nutrition being healthy as opposed to nothing but carbohydrates. And then how long were you cooking a meal, how long were you eating a meal, and were you cleaning up after a meal? That ties into mental health. How many footsteps are in the living room? If it's just your 2 footsteps and maybe the 4 footsteps of your 4-legged friend, you're not really socializing. If you have sometimes 4 sets of footsteps and 6 sets of footsteps, somebody's coming over to see you, and how long were they there? So we were getting mental health, nutritional health, hygiene in terms of bathroom visits, a little bit of moisture in the air, that's the sink. A little bit more moisture, that's the toilet. A lot of moisture, that's bathing. And we can see that cycle go through. So you can begin to, it's like an impressionist painting.
Yeah.
The further back you are and the more data you gather, then like a Seurat, suddenly you see what the artist intended.
There's a ton of data. So in this story, we have AI taking in the vital sign data and making, at least the initial triage of what's good and what's bad, and then sending it out. But currently, there's some AI out there that's doing this, but for the most part, systems are using people. And what I keep hearing is we got to send this to the primary care physician. Send it to the primary care physician. Like they will triage all of this stuff. And I keep saying, no, the nurses are going to do it. That's what nurses are really good at. So I'd love your opinions on, until we get reliable kind of analytics and AI that can triage it like we saw, who should be looking at this data and who is it relevant for?
Well, I'm a little bit of a geek, so I always say get the human away, at least for the beginning. I think that, and we're not substituting the human. We are basically empowering the human by letting the human focus on things that we're better at than the algorithms or AI systems and robotic systems are. But I think that there's already plenty of technology out there in AI systems wise and deep learning systems wise that can really be the first concierge that the patient is exposed to. And there's plenty of proof, and that will be exponentially, much more very soon, but proof that these systems are better than us at what, this objective imaging and data analysis, and we already have the wearables that provide the data. And I was reading an article recently that a DeepMind is in the UK is a division of Google, or so the AI of Google, and it's amazing, but in 2017, the FDA would approve 1 or 2 AI in healthcare systems a year. And last year, they approved several, more than 10 or 20 platforms, AI in healthcare. In just 1 year, went from 1 or 2 to 10 to 20. So that tells us how exponential the change is. And we know that the best results are not with the human, not with technology, but with the mix of the human and the technology working together. Like Kasparov, playing chess, no one could be a master chess player and a computer, not even the computer alone. And that's the way it is.
Well, I agree with the incremental approach to taking on technology, and it's how to deploy it, because we've hit a lot of brick walls in launching our businesses. But we found in the elder care example that we just simply made a dashboard. And the first thing we did is say, let's take a small facility, 30 patients, participants, 30 elders without severe memory problems and all of that. And so this dashboard would display by symbols, which you could learn very quickly. And it's the old red, yellow, and green. If the spots are green, you leave those people alone, because elders are always complaining if somebody's knocking on their door. Then there's the yellow spots that you better get to those today, tomorrow at the latest. The red spots, that's where all your staff has to concentrate its efforts. And so that alone, just displaying the spots in the dashboard, and if they weren't certain exactly what was going on, they could touch the spot, and then it would give them more information. So that evolved to being something where if there was a bathing issue, then a orderly equivalent was automatically dispatched. So you could start picking things out of there that were, you could automate the intervention. And then we just got more and more and more complex. And I kind of, when my companies get sold, I kind of lose track of it. That's when it's a great opportunity to invent the next generation, kind of jump over what I did before. But this worked beautifully to incrementally bring the caregivers on, and they were self-trained. So you could take somebody with a high school education and turn them into a sophisticated elder monitor.
No, that's a good point. I saw a recent implementation of a risk monitoring tool at one of the hospitals in the Bay Area, and it was driven by 100 data points instead of the early warning score, which is driven by vital signs and like 3 data points that you can touch and feel, and the clinicians didn't trust it. They didn't trust the AI. They didn't know where the number came from. They didn't understand how it was all calculated. They really didn't put their faith in the computer, and it wasn't rolled out incrementally. It's like, here's something you've used for 30 years, and then here's a new number that's completely different, and we haven't really trained you on it. And there was a lot of pushback. They actually had to pull it out, and they're back in the design phase to figure out how do they display information in a way that clinicians can trust and understand. So, Rafael, I wonder, what are your thoughts?
Pull out the human or pull out the AI?
Well, yeah, which one, right? Well, and the AI was proven. They had research where it was statistically significantly better than the current practice, but because you can't put your mind around how it was calculated, there was some trust there. I don't know if you have thoughts on that.
No, again, I think it's just, it goes back to education and change of culture. There is so much to learn, and the world is such a different place in every industry and every phase of what we do, and you just take education, and at the end you're going to have to accept it, and I always say that when the typical question of will technology replace humans, or will surgeons be replaced by robots, or AI replace doctors, and the words of Vinod Khosla, that investors, 80% of doctors will be replaced by machines, and I'm not sure about what numbers, but I do know for sure by what I've read and my experience, and I think that we'll all be, to some degree, what we do today will be to a great degree replaced, not maybe us, and I don't think us as humans, but we'll have to evolve. Like I was having this documentary filmed in LA last week about the use of how 5G is going to impact healthcare delivery, and so I went to the studio and they were putting makeup on me and all this. We were in a single room, all painted, in special color, and they had like 1 million iPad-looking devices and a bunch of computers and all the cameras and phones and tablets, and they were talking to some guy in Japan who was telling them if the set was all right, and all this amazing stuff. And the guy asked me, how do you think, are you afraid that computers and electronics are going to replace what you do in healthcare? And I told him, what are you talking about? All this stuff that you're using, you didn't even have 5 years ago. And the way they film we were there all day, and it's a 1.5 minute short little video on for a telephone network. And I said, look at you. You are not replaced. You're just empowered by this technologies to do you better, to do a better job. And I think it's exactly the same. We need to adapt, and we need to then become better humans in the way of emotional intelligence, empathy, compassion. Those things we need to then heighten. And the ones who are going to be replaced are the humans who are not able to then reach that level of humanity. Those will be thrown out because they're not good for what the computers can do better, and not good for the humans should be doing.
Yeah, it's like Rogers' diffusion curve, right? 16% of any population will be a laggard, and they'll be the ones, but the ones that enhance their practice with it may be more relevant. Yeah. So we're going to move to the next video. So this second part of the video, we're going to follow Leo's journey. So you saw he got his LASIK, the car drove him home, and he went home with home monitoring. And now his care team is meeting. So he has a pretty complex care team. He has a navigator, Gary, who you see the back of his head there. And then he has a nurse practitioner. He has his primary care, or he has a geriatrician, and I think he has a cardiologist. And they're all meeting to talk about what the prognosis for Leo is as far as mental health and his congestive heart failure. So we'll watch this, and I'd love to hear your thoughts on the workforce of the future, and you'll see some AI, some genetics, and just love to hear your feedback on that. So go ahead and play.
Hi, guys. Thanks for being on this call. It's been a few months since we discussed Mr. Montgomery, and given his recent episode with an irregular heartbeat resolved with a prescribed diuretic, I think it's important to take a good look at his current state and care options. Henry, why don't you take it from here?
Well, in the last few days, Leo's potassium has been a little low due to the diuretics. That should normalize as we shift his diet, fluid intake, and provide potassium supplements. Samantha, what's the status of Leo's congestive heart failure?
Based on his echocardiogram, his ejection fraction is lower than normal, but still within a range that we can manage with medications. I'll adjust his medication based on his genetic makeup and enter these into Health Connect so you can see the changes. With these adjustments, his CHF should remain manageable.
Any new developments in the cognitive testing, Allison?
Yes, the results indicate that he is experiencing memory loss. Unfortunately, Leo has mild cognitive impairment. And for many of my patients, this is when we begin planning enhanced care.
I'm just concerned about placing him in any facility before he really needs it, because Rosemary is still fully independent and is actively involved in his care.
They definitely want to stay at home as long as possible. Let's pull together some scenarios where we can make that work. Henry, could you be on the call with me tomorrow to walk them through the latest diagnoses and potential care options?
Sure, that's no problem. I'll see you at the meeting tomorrow.
So I think the biggest innovation I saw here is that you could get all the physicians and nurse practitioners together on one call at the same time. But there were,
talk to each other.
Yeah, to talk to each other in a respectful way. But also there's a lot of FTEs involved there, right? So there was AI, there was some predictive things, and there was a lot of FTEs. So I wonder, do we need all those people involved in that care, or is there some role for technology to not replace, but to not require a synchronous call for one, person?
Yeah, I can weigh in on that for another example, that we've developed an app that allow any medical professional to walk through the diagnosis of not only hypertension and predictive diagnosis of hypertension, but also determining if there's some underlying salt sensitivity. And you can have hypertension and salt sensitivity, you can be hypertensive, but if you're salt sensitive independent of hypertension, there are no diagnostic tools to measure that. That's 18% of the people in this room are going to have that reduced life expectancy due to the excess salt. 11% of you, here's the good news, need to eat more salt to lower your blood pressure. So if you look at the continuum, it really is a continuum from those who need a lot of salt to those that need a little bit of salt and everything in between. And the people in the middle, the salt-resistant individuals, have a wider latitude of how much salt they can eat in a day and not create cardiovascular fallout. And so this app has been developed. We've actually developed new diagnostic tests who can get the real stealth killer of which is salt sensitivity. And so it's essentially asking living cells in your urine how they respond to salt. So a random urine sample, we isolate the living cells, we challenge them with salt, and lo and behold, those cells respond identically to how your kidney responds in vivo. So it's kind of like a window without having to do a renal biopsy, and a very easy specimen to get. So that's going to change the whole, who's going to be part of your care team? Well, you've got an app. You're having a non-cardiologist would be just fine. You walk through this thing, and once you get your diagnosis, then we watch for blood pressure dipping at night to see where you are in the spectrum and what you need to do to maintain that health. And so we've just really had one health professional armed with these tools. So we're developing this. I'm a director of laboratory medicine, but I'm pulling this cardiovascular thing out as a separate entity whose sole purpose is to measure these new tests armed with this app, because if it's 50% of this room has the hypertension salt sensitivity spectrum and the other half doesn't, which half are you in? So really every man, woman, and child needs this test. That's going to be an avalanche in terms of laboratory medicine, but that's the good news. We've got answers. You just need to move the needle forward.
When I was watching the video and it's excellent, I was thinking, what's new about this?
Yeah.
Because really, we do talk sometimes. We meet face to face in the hospital, and we review different data points and all sort of variables that we gather when we look at patients. Now we're talking inside the hospital, obviously, but yeah, I would say this is what should be possible and the way healthcare should be today. But then in the next 5-10 years, yes, it's going to be an AI and should be an AI platform that really will do the thing that all of them four were doing, and then come up with then a person who will then be the human connection with the actual patient. And that brings us to who's that person. You'll train another, or the person who the cardiologist will then become some sort of humane summarizer of everything, and then get the patient to really engage and with empathy and and compassion and emotional intelligence, push the patient to behave differently maybe. So another new career, for and when we're telling kids, oh, what are you doing? I'm going to med school. I'm pre-med. Well, guess what? But by 10 years from now, when you're a cardiologist or a neurosurgeon, or that might not exist anymore.
Well, that's a great lead into the next question. So Kaiser Permanente is building a new medical school. We just got accredited. It's opened in 2020. Dell just built a new technology-enhanced medical school. Others are starting new medical schools. What does that future curriculum look like? And what needs to be disrupted in medical education in order to live a technology-enhanced future rather than a technology-resistant one?
I think everything needs to be disrupted in medical education. I think the way we are training...
We agree, by the way.
No, I'm serious. The way we're training, not just physicians, but practitioners in general, all over the world, but especially in the U.S., we're training the way we train 50 years ago or more. It's really sad that when you ask a student doing his or her fourth year surgical rotation, telemedicine, and they never heard of telemedicine. Or wearables. What are you talking about? Other than maybe Facebook or Instagram, they have no concept of how social media can empower you as a provider and a patient and family member. And it's very sad. And I think that the curriculum, and this is happening in a few very few examples in the U.S. and many more out there in the world, Middle East, Europe, UK, the Netherlands, the Nordic countries, some in Latin America even, and because they understand that if you don't train the next generation with these tools, by the time they finish in 4-10 years from now, they'll be completely obsolete. And that's what was happening now, that we're creating providers that I think, in general, with some exceptions, are obsolete to the task they have ahead of them.
Yeah, it seems to me, well, we all know that the medical profession is kind of an elitist profession, and you've got this medical layer, and then you've got everybody else. And we've proposed a long time ago that we just need a continuum where we're culling out from the entire educational program caregivers. There are people who gravitate to be caregivers, and we entrust our elders and our children with these youngsters who are babysitters, or when they're older, they're full-time caregivers. And to me, they really are medical people who haven't been given enough information or tools to do at a broader spectrum of caregiving. And so think of what you could do if you took high schoolers who weren't destined for college, culled out the caregivers, and that's a kind of a mental test you can do, and then give them the tools to do incrementally increasing levels of care as they mature into their profession. So it isn't just a wall. You graduate from medical school, now you're blessed with being able to treat people. You are taking care of well people and then sicker people, and depending on your affinity for this kind of thing, you can go up the line of your chosen profession.
Yeah. So one of the things we're struggling with is around where do you teach virtual care skills? Is that part of when you learn health assessment, you do it alongside the physical exam, you do the telehealth exam and it's right alongside, or do you teach those foundational skills and then do virtual care over here or wearable data assessment over here outside of kind of the hands-on kind of traditional foundational skill sets? Do you have opinions on that or thoughts?
I think that we really need to create a whole new curriculum in the way that you integrate everything. It's like in surgery, So we have robotic surgery, right? And you have the residents who finish up and they have done a bunch of robotic hernias or gallbladder removals, and then when they come up and be a surgeon in the real life, and then they need to take an open gallbladder or do an open hernia, or they get in trouble laparoscopically or minimally invasive. But then the training cannot be 20 years. It has to be, about 5 to 7 years. And then how do you integrate in the current curriculum design the training for that traditional and the new stuff that is evolving incredibly? And the resident had just finished a robotic surgery training in their 7-year residency. Guess what? Next year there's going to be 5 new robotic devices out there that change the way you approach X or Y operation. So it's the same thing and you see how virtual reality and augmented reality and mixed reality are really changing the landscape in how we connect and how we communicate, how we teach. You have platforms that have avatars, and you can have a Magic Leap or a HoloLens, and you can be in a room with people, and you can, with gestures, interact with this virtual person, and the person can tell you and answer you questions. So improving your history-taking skills and even your physical exam skills. It doesn't mean that you're not going to learn physical exam skills, but then you're not going to learn in the same way, because you're going to empower your learning by using technology.
Right. So alongside, you're making the argument for integrated,
absolutely,
learn it all in a continuum, not plugging technology care over here, but making it part of the foundation.
No patches.
Yeah, no patches, right.
I was recently at an agro-automation conference. I'm a farmer, and it was really interesting what's happening with robotics in farming. But one of the keynote speaker was Terry McAuliffe, the former governor of Virginia. And so it was remarkable. The first thing he said, and the room was full of students, and he said, I'm going to eliminate, when I become president, I'm going to eliminate all classroom teaching. And I said, no, there's a statement. I had to think about that for a couple of weeks before I finally realized that e-learning is what every college is going to be surviving on in the future, is you take distance courses and you interact in very different ways than sitting in a classroom. I know I was never a classroom sitter. I would fall asleep in the corner, because as soon as I'd heard enough that satisfied me, my brain was going elsewhere. So why don't we learn independently and incrementally? And I gave you that example of the dashboard that taught the caregiver how to learn to be a better caregiver. Ultimately, it has to be the future.
And hopefully it won't cost $250,000 after 4 years.
Well, like I said, I told you that this case-controlled study we did, it reduced the cost of care, actually reduced it by 75%, but as a businessman also, I discount things. So
I meant the schooling, I meant college.
Oh, yeah. Well, there you're learning on the jobs. You're getting paid to learn.
Yeah.
How cool is that?
Yeah, absolutely.
So lots of disruption in healthcare needed. And one of the battles, which is funny, is the battle between foundational or basic science and clinical science, and how much you need of each one. And we could go deep into that if we wanted to. But I'm going to switch this a little bit. In that video, we also saw very seamless use of technology, which we heard from Nick. We've experienced ourselves burnout. The EMR is not helpful. It causes a ton of burden on caregivers. There's some solutions like augmetics and scribing, and it seems like we're still trying to solve technology issues with archaic solutions, like let's hire another FTE and have them scribe for us, but let's use Google Glass to have another FTE scribe for us. Do you think we'll ever get to a seamless future within the next 3 years, to where we're not fighting the technology and it actually is enhancing our work, or is that still far off?
No, well, I think we'll get there, but not in 3 years, I think, because we're patching, Cerner, Epic. You put patches in, you have to disrupt it. They say that I am a healthy a healthy...
positive deviant?
I have a healthy disrespect for authority. I think that you need to...
That's positive deviance.
We cannot use the same systems that were designed for like analog in digital. I really think that it won't happen in 3 years, but the system is to a point where it's about to collapse, and it's unsustainable. The cost, the burnout, the lack of patient human interaction. You go to any hospital and they're full, they're red status all day. I say, why do you have colors? So it's always red. It's always your diversion. It's always, and you can't move people fast enough. And I think that that you know, the EMR, while the concept is brilliant, and that's what we definitely need to, because you know, you need to use technology to help you, you know, care for patients, but the EMR has been an experiment that is completely failed in the way it succeeded. Yeah, it's great for billing, but nothing else, I think, because all you do is produce suffering in the providers, and then worse, better care. I mean, worse improved care is worse care overall, and the outcomes are not better. You know, the amount of errors out there from trying to use EMR. We have providers that, you know, to discharge an operation takes 15 minutes, and to discharge the patient in the EMR takes 45 minutes. It doesn't make any sense.
Robin, you do a lot with automation, so I'd love your perspective on that as well.
Well, it's all my professional life I've been involved with what I call a greenfields project, where some medical system had an open field and they needed to build another hospital. And systematically, every one of them have melted down, and what they did is built an antique, just because they're using traditional values to build a traditional health system. When disruptors like me get in there, and they, you know, you have to have an open mind. So again, back to the administration being able to say, okay, we can take a risk here. But I believe greatly in private-public partnerships, in the sense, if we can get everybody to Mars, and it's going to take a heavy dose of private investing, Elon Musk maybe, to get that done, why don't we start with the greenfields and build the ultimate prototype medical center, which is not, it's a hospital only when necessary, but it instantly outreaches into a broadening community. And it'll be wildly profitable. Undoubtedly be wildly profitable. I went into a large health system not far from here, and they had 6 hospitals, and they said, we need a central laboratory because it's going to be less expensive. And we have a problem. Nobody wants to be the first one to give up their laboratory. So many years in the future, we designed probably the most profitable clinical laboratory. It's like a bowling alley. All the samples get delivered from the 6 hospitals very rapidly. It goes down a linear process, and the medical waste accumulates for the 7 days required, and then it gets discarded. So there's nobody interfering with each other. They have 4 people on a typical shift running 6 hospitals worth of specimens. That's an unprecedented reduction in labor. And on top of that, they are only operating at 5% capacity. They still have 95% capacity of growth to compete with their competitors. That's what I call minting money. But also quality. The error rate has gone down, and I was only able to really do about half the job I wanted to do. For instance, you have to feed all those instruments that are measuring all those tests with reagents. Well, that's usually a manual labor. So I said, why don't we just deliver a container that can be disassembled and inserted at the appropriate point at the appropriate time? So just a one delivery takes care of about 20 people feeding machines. It's not a very gratifying job. So
fascinating.
You know, I loved erector sets when I was a kid, you can imagine.
You know, I'm from Maine, and I guess the motto in Maine is the way life should be.
Exactly.
So what do you do with those other FTEs then? I mean, you displace the lab, you know, the lab folk that worked in a regional lab. Where do they go? The
biggest challenge in medicine today is getting trained medical technologists to do all that technology stuff. 70% of all the decision making made in medicine is done through the clinical laboratory. And you know that in your field, and you certainly know that as a surgeon. So if you've got all that need and you don't have enough trained professionals, we have essentially a vacuum we need to fill. Yeah. Mm-hmm. And so the automation is filling that vacuum without disrupting jobs. Mm-hmm. In all the projects I've done, we've never laid anybody off. We've just essentially dealt with the vacuum and replaced it with automation. Fortunately, the lab automation field grew fast enough to fill that vacuum. Well, way back when, I said, I saw my first robot, human scale robot, because most of them were the big monster machines for building cars. And I said, that's the future. So I started the Association for Laboratory Automation, which is now the Society for Laboratory Automation and Screening. But there it's about 6,000 people show up every year, acres of show and tell, and we're in the US and in China and Europe. And so you just have to start a field and pump up the pump. And then, so the field making major strides there. You were telling me pharmacy is making really great strides, and I saw the beginnings of all of that. So these are the kind of the more factory sides of a hospital that can be done. Sterile supplies next. dispatching the appropriate person at the appropriate time. You can just whittle away at those things that are highly labor intensive but necessary and just work your way up.
Well, it's that fourth industrial revolution. You know?
Yeah.
It's what it is. And
Well,
like any revolution, there are going to be some changes on what specific humans do, but doesn't mean that they're going to be laid off and they're just going to be retrained, or new jobs that we don't even imagine yet are going to be created. Yeah. So, it's
Well, I've started another nonprofit called Medical Automation. You're welcome to sign up. You get a newsletter every Tuesday at no fee. Just all the new stuff happening in medicine. The former health science curator for the Smithsonian helps me edit this newsletter. So he collected the first of science and medicine for 40 years. So he's got a vision, historical vision, that particularly that people don't have. But that's kind of the next wave. How can we get through all these political barriers and say, healthcare, $2 trillion in the US, probably $1 trillion of it wasted. Maybe that should be our priority, and do it with aplomb. Get in there and really do it, and take apart just speed up the evolution of the current system is all we need.
So I'd love to take it into the audience. So I think some of you have been putting in questions, and if not, start doing that now. If we have some questions, can we show them? So we'll go from the top. So what is the likelihood that clinical schedules align? Well, yeah.
We answered that.
We answered that one. Not likely. What is the name of the ring?
Okay, the ring is the magic ring.
Yeah.
It'll
the precious.
Teleport me home after this conference. No, it's existing technologies, but the individual who invented it was the inventor of the principal chip that enabled today's gaming for children. So he's an electronics wizard, also a physician. So it's called Sensogram is the name of the company in Plano, Texas. And this is the Senso ring, and it has an app. And we're still working on the battery power to get it to go a lot longer, but that's just inevitable. Batteries are moving at light warp speed. But the issue is that I can get a whole night of blood pressure dipping. And I'm borderline salt sensitive. I've been through my own studies many times, and so I need to watch my salt. And after eating in a hotel situation, I flatline, and then a few days of low salt, my dipping's coming back. And so, it just makes you feel really like life is good.
Yeah,
awesome.
So the third one there is, where's the holdup in the adoption, and where's that going to take the longest? And then I would add on to that, who's going to be the first to disrupt? Is it going to be a health system, or is it going to be the Apple, Google, Amazon, Berkshire Hathaway kind of crew that's coming in?
Yes.
And Walmart.
Because Apple will team up with some health thing, and maybe that green field will actually get filled with something appropriate.
Do you think they have the user base to push the adoption curve over and kind of push through the resistance of the traditional system?
You think Apple doesn't
Well, I know they have enough users. But in healthcare, what I've found when I've talked with a lot of tech companies is they want to get into healthcare, but they know nothing about healthcare. And then they hire a bunch of healthcare people, and they still don't know anything about healthcare. And when they try to disrupt, they don't understand the system enough to be disruptive, I guess.
Yeah, no, I think it's happening already. You look at Amazon and what they're Atul Gawande's CEO for the new a joint venture with
Avon.
I can't remember the three names right now, but two of the money people,
right.
And then Amazon. So it's happening already, and they're starting, and they start with their own employees, which are in the thousands and thousands, and then they will basically export all that knowledge to it's going to happen. But you also have very disruptive healthcare systems, in a way. Cassie being an example. So it's going to happen no matter what. I don't know the time frame, but it's probably going to be within the next, I would say, 5 to 10 years.
And which group is the most resistant? Is it physicians or clinicians?
Yes.
Yes, it is physicians. No. Is it clinicians? Is it the systems? Is it the payers? Who's the biggest?
It's the payers and health systems have evolved to this point today. We have currently, the battle going on politically, so we're at actually a good time, because it's so bad that it just has to get better.
What is your prediction on having that ring or wearable technology being durable medical equipment and being just part of your health plan?
Oh, I think that's a given. Fitbits are given out freely at the University of Virginia.
Yeah.
I think it's give them away, to foster good health. So the better the tool, the better the outcome. Thing is, we need outcome studies. That's what I'm involved in doing, is raising NIH money to do outcome studies so that we can have the hard data behind it. And that's the problem. The early Fitbit kinds of technologies, and I have slides full of it, I give in lectures, about 80% of that's all gone by the wayside, simply because they didn't have sustainable technology and evolving technology, and because they weren't involved in case control studies to prove what the point is of this thing. Now that we can do equivalent to an ICU in terms of, if you can get breathing and oxygenation, you can find not only apneas, but you can find hypopneas, which are subtle apneas that happen frequently. So there's a whole world of these subclinical things. We're essentially treating train wrecks as opposed to getting way back early when you're having hypopneas, and we can avoid the apneas. So we're getting into that realm where the data is really deep in terms of what's going on with your physiology.
You know, I think that the devices that we're using for our normal lives, now more and more, they have, you know, the ability to be health devices. You know, look at the Apple Watch, for example, and the next version is going to have even more and even more, even more, because it's really not, you're not going to buy a device or get a device just to measure this or that health. It's going to be the same one that you use for texting, for emailing, for looking at the time. You know, the very popular book now already, Dr. Topol's Deep Medicine, you know, he talks about the 3 Ds, the democratization, the digitalization. All those are not quite there yet, but we are going to get there, and we're getting there slowly. And then the deep learning, we have the deep learning algorithms that are going to help us figure it out. But all those 3 Ds are going to happen, and they're going to happen with devices that are going to last for forever. You know?
Sure. We'll come back to that top question around single pair, so I'll give you a second to think about that. But we'll go to the next slide that we had, if we could. We'll follow Leo's journey. So Leo has some memory decline they found in his cognitive testing, and he's given choices in order to be part of his own care. So he's given choices, and each one has a different trade-off, and we tried to graph what that could look like. So here, he could stay at home with caregivers. He's not quite independent anymore, but he could stay at home with caregivers. So the level of care is high, his independence low, and the cost to have someone in your home is pretty high. We can go to the next slide. His second choice is an adult daycare center, which level of care is lower, his independence is a little higher, but the cost is medium. And then the next, or he has the chance to go home with devices. And so the level of care is lower, or I would say maybe medium because of all the advances. His independence is very high, and the cost is relatively low. So what do you think Leo chose? Of course, he went home with home monitoring, because it would be a boring story if not. So, well, he did go home. We go to the next slide. So these are some things that we have already in the home. So smart fridges, activity sensors, there's fall detectors, there's occupancy sensors, some of the stuff we touched on now. But my question to you is, how would you outfit a home to keep yourself completely independent if you were having, you know, mild memory decline, and how would you outfit a home to be super censored, I guess?
Well, we did it 10 years ago. And so
expensively.
Yeah, right.
Well, no, the cost of goods was less than $600. I mean, it had like a 2-week return on investment, but it was just too early. It's the story of my life. 10 to 20 years too early. But the point is, we did it, and it can be done, and it's now out there. Like I said, I think there are various iterations of it in 6,000, but it has everything. That's essentially my slide from 10 years ago. Where'd you get that?
So how would you enhance that? What would you put in there now that wasn't back then?
What we need is mental health, for sure, and that can be done through what I intimated about socialization and all of that. Also, what programming you're watching on the TV or listening to on the radio can have great things. Also, this issue of blink rate is directly related to mental health or memory impairment. And so one thing I created was a very tiny analyzer that goes in your tear duct. Everybody goes, ugh, tear duct. Well, there's 1 million people in the United States that have plugs in their tear ducts for dry eye syndrome, especially after LASIK surgery, it cuts some nerves. And so I said, if there's 1 million people with ducts in their things, we just have to swap one out, and it'll measure tear glucose continuously. It'll also measure a whole raft of other things. It's self-powered because every time you blink, it's about 20 meters per second square of acceleration. Convert that into energy. Your eye is only closed 4 minutes in a day because the blink is so quick. So why wouldn't you just essentially have this little plug that is resident, it doesn't have any discomfort, and it measures mental health, chemical health, physiology, just go down the list. Now, we're not ready to stick one in today, but the patents are there, in case there's any companies in the audience. So, but the issue is, this is the kind of technology that's not, it doesn't break skin for chance of infection, and it's not wearable where you forget to put it on after you've charged it. This is resident, and it's just a question of what the economics will bear as to how often we have to swap it out.
Sure.
And so that's the kind of technologies where we could be very
So
soon.
integrated into everyday life where you don't even notice it. Yeah. Raphael, how would you outfit a home?
Yeah, I think that you have all that stuff, like Ron was saying, it's already very doable, and many homes actually have that kind of stuff between what's in the home and what's in the person. But you think wearables, and you think ingestibles, and you think not just mental health, but you're able to really detect mood. You're really able to air quality, light quality. All those things put together. Even brain activity. You have sensors that are available 5 years ago that you can put a little band in your head and the Muse band, and you learn how to meditate, for example, and basically you have a portable EEG. All those things are possible and will be part of. So now the question is, how do you integrate all of this, and how do you will people. Where is that data going, and who owns the data, and privacy? That's a big deal and a big question, and one of the reasons why people doesn't jump on that quite a bit.
So we've taken some patients through this story as well, and we've asked, the story goes on to where the home is actually programmed with his daughter's voice, so it's comforting to him, and he can recognize it. His wife can be at work and monitor him at home through the video, and we asked families, who would you want this technology? And the aging parents were like, no, get that out of my home. And then the kids are like, no, we want that for mom or whatever. And so there's this big divide. So where do you think we are on the patient adoption of this kind of stuff? Is it too 1982 big brothery, or are we close to having this as norm? I know a lot of us in this room are early adopters, but what do you get the sense of patient adoption for something like this?
We actually published some hard data on this, where we actually quizzed these elders, which we had been monitoring, and asked them, what are the issues for you in terms of lack of privacy and all of that? And it was an overwhelming response over the age of 60 that if I just feel safe, and I know my loved ones know that I'm safe, and if I'm not safe, they're going to intervene in a correct way, not what the institution wants for the intervention. So that was remarkable to us, because we thought, one thing, we don't use cameras or microphones. So if you're not doing that and it's just on-off signals, then that's not very, not as intrusive. But the safety issue is what elders want. I'm getting there really quickly here.
Yeah. No, and I think that I always say patients are the first adopters, and the ones who, they don't care if you have antennas coming out of you. If they are going to be healed better and it's going to be easier for them, they'll adopt the technology. That we looked at that with Google Glass early on, and patients didn't care that we have a frame. They wouldn't even notice that. As long as they could have better care and better interaction, and at the end, better outcomes. And I always thought about this as the driving Miss Daisy syndrome. You guys remember that movie? You don't want to have the driver, you want your car, you want to drive, but my grandma, you cannot drive anymore. It's not safe for you or for anyone else around you. And then at the end, you kind of fall in love almost with the driver. So I think it's the same. I have a 93-year-old father who basically uses his tablet in Venezuela to FaceTime with me every few days, and he's 93, and he didn't know even how to turn it on, a few years ago, and now he can't live without it. So same thing for all these new technologies from the patient's perspective is always education, and more education, and then the other issue of privacy and how willing are you to. But I think that once we know whose data it is, we know already, but once we recognize that it's the patient's data and who has access to that data, then it's not different than your computer or your telephone or your cell phone.
Great. So, there's a lot of talk about care moving into the home and hospitals getting smaller and becoming just big ICUs and only doing surgery there and nothing else. I guess first off, how far off are we from making that a reality where hospitals are just big ICUs and the sickest of the sick go there? And what do we need in the home in order to be reliable that we can send every med-surg patient, even on titrated drips, home without having a care provider there?
I think we're still far from that. At least in the U.S. we are.
Yeah.
Certain countries are really much more advanced than we are, unfortunately. But you know, I would say that probably not within the next 10 years or so for that type of completely hospital-less care.
Okay.
Yeah.
Well, I think we've seen the evolution with the MediQuick kind of clinics. We're pushing a lot more of that health care into the community, and they use in-out kind of surgeries, so it really works.
Sure. And as far as roles go, so, you know, one of the provocations that we get when we show this is, you know, is a health system like Kaiser going to go into your house and install this technology? Who's going to maintain it? Like, what is the business around that? So what roles do you see being created with the advances in technology, home monitoring, wearable technology? What are the new roles, the healthcare roles that are going to have to be out there that aren't currently in existence?
Well, that actually was our Achilles heel in the first rollout of this kind of home monitoring technologies, is just getting it installed and make sure it was operational. And then if it was not operational, the internet wasn't what it is today back then. So we had to essentially face a lot of challenges. But we found tech-savvy people to join the company, and their job was to fly all over the country initially, and then we had, you know, various outposts, and they would just go in and maintain, much like your dishwasher. I mean, I spend every weekend fixing dishwashers and refrigerators and freezers, so it's nice to have those kind of services if you can't do it yourself, but it's just a whole new breed. And think of the appliance explosion that's going to happen and the degree of technical complexity of those explosions. But we need plug and play. I mean, if we have, you know, try to go into a freezer, all these freezers and dishwashers were designed in the 1950s, and they're all piece goods, and you need a module. If you walk into a clinical laboratory today, an instrument is nothing more than a computer, and it has this box you buy, and you slide it in, and now you have an instrument, and you do your work. And when that thing runs out, you toss it or recycle it, and then plug in another one. That's been a revolution in technology enabling that kind of easy maintenance. The home is going to have the same kinds of technologies. It's inevitable.
I think it's I think health systems are going to try to take that, to own that, and I think that'll be a mistake because you can't do it all, and you should outsource that kind of stuff. I think I see it as the Ubers and the Lyfts and the Junos of transportation. You know, why? I mean, there'll be a new job description there or training. You get trained to just be the cable guy, you know, at home, and that's probably going to be the future.
So Cox Cable, put your stock in there.
Yeah.
So let's go back to the audience questions, if we can. And there's mics as well, so if you have questions, please come up to the mic and we'll take some more questions here. And as people are thinking about that, you know, do you have, before we kind of dive into some of this stuff, do you have a final kind of provocation for the room as telehealth professionals, virtual care professionals? What would you challenge this room to do to advance that work? We can come back to it if you want to. We can take some of these. So think about that for a second. Okay. So let's see here. So let's go to the single payer one, because I already warned you about that. So many of the countries you've mentioned that have the technology and are doing the hospital at home are single payer systems. Is that what's needed for the adoption of this technology, or do you think there's a way to legislate into the adoption?
Well, I try to stay as far away from the money.
Yeah, I figured. We don't have, okay.
I'll give you something to use, but I'm not going to fix the financial woes of this country for sure.
Yeah, I go on that.
I was trying to be provocative. I get it. Okay, we'll move on.
Maybe you can weigh in. Maybe you can weigh in on that one.
No. Well, I would say an integrated health system is more incented to adopt these technologies because it keeps the cost low and people out of the system, which is more expensive. So I would say in a compromise that an integrated system, and I've had conversations with like the UC systems in California who are like, no, we're never going to do video visits because right now we're not getting reimbursed for it, so we're not incented to do it. We're going to send someone in the home because we can get reimbursed for that, so we're incented to do something different. And I think until that changes, or until integrated systems that are benefiting from preventable care are the norm, then it's going to be hard to adopt.
Thomas Jefferson said that medical education should be part of everybody's curriculum from the get-go. Mm-hmm. And as Americans, if we don't begin to start taking care of ourselves and not depending on the healthcare system to fix something we broke, until we get to that point, I think we're always going to be behind the 8 ball. Mm-hmm. And so if we could start in grammar school and teach frank medicine, so there are no surprises, there is no fear, it's just you're issued one body and you're supposed to maintain it, just like your bicycle, your tricycle, then your bicycle, then your car, mm-hmm. and your body. And you're hovering whatever in the future.
your dog walking drone.
Yeah.
So are there any known platforms that can collect data from a variety of wearables, and I know you guys know there are, and share that information with patients and the provider if the patient and provider are both on the platform or are not both on the platform? If someone wrote that question, I think we need a little bit of clarification.
Well, I think
go ahead.
Yeah, the fact is all that infrastructure exists. I can get, like the Sensogram app on the Apple is always alerts me when it needs updating. It does all the data gathering, so Google is providing that gateway for that technology. It's soon to be ready for Android if it isn't out already. So those infrastructures, and that's why Google and Amazon and all them are going to get the secondary fallout from medicine because they were providing the infrastructure, but they want to get closer to the cash register, and so you'll see that movement as we go
the health
forward.
kit, the health kit comes with every new iPhone for the last how many years? 3, 4, 5 years,
yeah.
And I have like 25 devices that get data seamlessly. I don't even have to think about it to my health kit. If I open health kit, which I don't usually, it's all there, and I go back and months and months of, from blood pressure to temperature to sleep to this to that, how many miles did I walk, stuff that, in my personal, thank God I'm healthy, and thank God thanks God I don't have to look at it everybody if I wanted to, it's all there, and even better, if your provider wants to look at it, it's all there. So it's all happened already, and HealthKit is just one platform. There are many other platforms that are not as big as Apple,
sure.
a platform that do it for you as well.
Yeah,
and every device has its own platform.
Right.
Also, so.
And I was at South by Southwest last month, and I saw a company called Seekster. It's Seqster, and they took a different route where you go into your EMR through the patient portal, and then they pull the data out through the patient portal. So they can actually go through Epic, Cerner, whatever health system, and pull the data in, and then they match it with wearables, and they match it with your 23andMe data all in one platform like a mint.com. Really interesting.
What's the name again?
It's called Seekster, Seqster. But it was something I hadn't seen before, and it seems like such an obvious play into getting medical data. But they go through they use your patient portal login just like Mint uses your financial, and they put it all in one spot. And now they're actually using it to onboard patients to new health systems because they can get the data instead of faxing it to each other. They can pull it and just have the patient log in and pull it in. So it was interesting, very disruptive thing out of San Diego. Yes, I see one on the mic. Yeah.
Thank you. This is wonderful. The whole conference is wonderful. My first time. I'm from a VA system and been doing telemental health since 2007 after hearing about it. What I'm fascinated by, we haven't talked about, I saw that lovely curve earlier to death, and we had fun, no fun, or,
right.
Moving us back to fun. What about, in this poster, there's palliative/hospice options. Could we have you thought about moving joy? And I love the fact we have increased independence for those who are able, but how could we move no fun to something like the joyful end, move positive direction toward acceptance? Is, it's part of the last stages of life is to get to, and to not be miserable, and
right.
Wherever you happen to be. No. I've seen one psychiatrist developed, I think, I'm geropsych trained, so I like general psychiatry, but at a geriatric meeting, had videos of family for demented patients that you could just keep going around and around because they'd forget it, happy videos, and that calmed people down. I mean, that's easy, but what else have you thought about those things?
That's a great provocation, and there's a great conference too called End Well that it started out in San Francisco. That's all about dying and technology and ending well, basically. So that may be something to check out just as a resource. But I'd love your guys' thoughts on.
No, I think that I'm good friends with Nick, and his life was great. But you know, I don't think there's fun and not fun. There's no age to fun and not fun, and it's just about your not even your health condition, because it could come at any age. It's really about your take on the health condition, and you have a lot, especially today, you have a lot of people who are at the very far chronologic age, and health-wise they're not doing well, and they have all this empowerment with all these technologies to look at my father, 93 years old. He calls all his 8 kids every day with a FaceTime, and he's having fun. And so it's different fun that he had probably when he was 20, but I don't think that there's like enough fun area. I think there's a lot of a change in the way the end of life or the last few years of life happen. And even when you talk about hospice type, end of life, imminent end of life, there's a lot of things that are being done with technology to make those people and the people around them to have much more fun than they would 5-10 years ago.
Something we spent a lot of time thinking about in our group. My wife and I were the sole care providers for an end-of-life ALS patient who was a nurse and medically trained, and that was an eye-opening experience, and it was a very rapid onset, rapid endpoint. But so as soon as I get done solving a few other big problems, that's my next thing. As I approach that phase of my life, there's a lot that could be done there, and it's just a matter of making the right kind of measurements. If we can ever get a handle on how to measure pain objectively, and there's all different kinds of pain, in terms of sadness through nerve pain. If we can ever measure that objectively, I see that as kind of, in my mind, the gateway to being able to come up with solutions to deal with making that transition just as pleasant as can be.
And I want to add, I've been working with the VR and AR and mixed reality for the last maybe 3 to 5 years, and just came back from LA, Cedars-Sinai conference. I was a keynote there, and it was about VR in healthcare, and a lot of emphasis in geriatric use of VR to have elderly patients regain a lot of the stuff that they have lost in regards to mobility, connectivity, communications, and they have patients who are very, very ill, barely mobile, and they get any of the many VR headsets with the right platforms on them, and they can now just connect with their loved ones who might be situated elsewhere, but they also get special personalized experiences in VR for them to live the joy of life, being sitting in a wheelchair or in a bed at 85 years old. So technology is really, really getting a different outlook for these people.
May I ask another question, a quick one? Is there actually a test for hypopneas now, or are you just hoping for that?
Now, when we deployed, one technology we deployed was a mattress pad that would do the same thing that the ring is essentially going to take over. But there we had about 85% correlation with polysomnography. So that's an awful night in the hospital where they could make you wire up like a spaceman and say go sleep normally. Well, this is in your home every night of the year. And so if we could get 85% correlation, and that's what we saw was hypopneas were very visible in this kind of scenario. So I think that technology exists. It's just a case of, now our patent expired and Nokia has taken on the charge to, I'm not sure where my mattress pad is out there somewhere, but Nokia now has one. So there's something you can buy off the shelf. And I would almost guarantee it's going to be, I would ask that question, how close is this to polysomnography? If it is, then you'll get all the hypopneas.
Wonderful, thank you all.
Well, thanks for your questions, bringing that whole end of care thing.
Yeah, that's a great conversation.
Yeah.
I have another question on the mic.
Hi, I'm Diana and I'm from West Virginia, and I can't wait for a driverless car and Rosie the robot in my house, so I'm all about it. But when you look at healthcare and you look at the divide between urban and rural, then you also look at the lack of infrastructure for broadband and internet in rural. Is this another factor that's going to create a deeper divide between quality health care in urban areas versus rural areas? I mean, I know it solves some of the work related workforce issues. But if you don't have technology in your home, none of these options are going to be available to you. So how do we make sure that this isn't another dividing factor, that this is something that helps to close the gap between urban and rural?
So my guess is that the fact that we're going to have eventually geosynchronous satellites giving us global data communication, that for once the United States is going to be the beneficiary of that, because our rural challenge isn't nearly as hard as it is in the middle of Africa or some of the far reaches of this planet. So that's inevitable, is to get globalization of internet. USA divide in terms of rural access won't be there anymore. It's just the distances. So you'll be able to know what your health crisis is. Maybe the drone technology will go scoop you up. There's some great Army projects where they've put a lot of money into being able to rescue soldiers from the battlefield, because there's wearable sensor, hopefully in their eyelid, will let them know that...
in their tear duct, right?
In their tear duct, yeah. We'll let them know that there's a challenge. The drone scoops them up. There's actually surgical intervention on the way to the hospital. So all of that, the fallout of that will be rural health, will be the ultimate personal ambulance.
And like I was saying, the digitalization, the democratization. Initially, eventually, obviously, there'll be probably more of a divide in regards to cost and location, but I think that will go away. I agree that even with 5G technology, that it's already been it's part of the daily life in a few countries already. That will be a big boost to democratizing, I think, access to a lot of the technology that we talk about.
Yeah, and Dr. Nick mentioned a few things, just text message as a data source as well. It doesn't need to be a humongous wearable or implantable or anything, but even just texting, what is your blood pressure today? Or texting, how are you feeling? Can provide data points back to somebody to help make an assessment. And so, the lowest common denominator there is a cell phone potentially, or even, even just picking up the phone again and calling people is still an intervention. So we'll take one more question off the screen here, and then I'll let you guys do your kind of closing provocation. So what are your suggestions for the new EMR? We talked about how it's horrible, and there's a sense of it's hurting everything, but what does that look like, and what features would you design into the ideal electronic medical record for you to love it again?
Yeah.
I'll wait for mine. No, when we started our home healthcare initiative, the first thing we did is found a open source personal medical record, and we married it to the health record, so it was a continuum. But that personal health record would self-populate from the data we were generating. But when the physician went in to have a look at it, he could see the continuum from frank health all the way through personal health. Having the physician, aiding the physician in interpreting what that really means, or is my health degree required for me to deal with this family spat over here? So there's a lot of data there in terms of interpersonal relationships, which influences our health quite a bit. So that's a kind of a problem right now. So I would say there's a challenge is to integrate the whole thing. I would guess that either Google or Apple are going to jump right in there, because they have your Facebook and everything else going. Sure. So you're self-populating your personal life, but now you're going to self-populate that piece in between.
Sure.
Yeah, no, I think the EMR definitely not what we have right now. I think that we need to redesign it, reshape it, not reshape, redesign. From the creative disruption of the EMR, and then go back to a new system where the way I envision it. I think about the four eras of computing. Where we are now in the era of spatial computing, right? We had the MS-DOS era with the black screen and characters, and then the graphics interfaces with Apple and the icons and the desktop, right? And then the next one was the touch interface, which is kind of what we use in a bit in EMRs today. But I think the spatial computing is you have computing on the space, you have devices that allow you, like the HoloLens or the Magic Leap, that allow you to compute with gestures on any space you are. I think that spatial computing with making good use of AI and deep learning systems, making use of facial recognition, making use of voice recognition, and that would be sort of the medium to get to the actual EMR. But the way the data is displayed, it cannot be the way it is right now, where you have 90% of stuff you don't care about displayed in front of you, and you need this special new language that you need to learn in order to navigate how many clicks, and click here, and double click, and triple click, and right click, and left click, and to get to one thing that you could say, okay, I want to know what the blood pressure was yesterday at 3 p.m. So I think that the display needs to be something that is user-friendly. And I think, I hate mentioning Facebook because I don't like Facebook and I don't even have Facebook, but I think it has to be something that will take on, the user will just join to this platform in a very seamless way, and like Instagram, you get, it's very easy to use. It has to be that way for the provider and for the patient. When you're a patient and you get these mobile portals and you're going to get, we're going to get access to your record. It takes a lot of steps to get to your record. It should be much, much simpler. For the physicians, the amount of time we waste getting to the patient. I sit an hour getting in paper, I put all the data from the computer and before I go around on the patient. And then I go back to the computer to put all the orders in. And that makes no sense when I could have a head-mounted computer that we had for the last almost 10 years and commercially available, where you can just go around and open up the patient's record even by just looking at the patient, and then have only the info that I care about. The info that I care about as a surgeon is the same, the different info that the pulmonology might want, and the data points that the nurse is putting in the computer. I might not care about a lot of them. I just how much the drain is draining, or how much, or the patient had a fever, or are they tachycardic. I don't care about many other things. Different specialties will have different needs, and it has to be personalized, not just for the patient, but for the provider. So that's an EMR that it should be that way. It should be a graphic interface that is completely seamlessly connected to both patient and provider, that uses all the technologies that we already have had available for a while to access and to input and get output from that, for the record.
Great. So for the last thing, I warned you that you have to have a provocation. So what would you, to move the dial forward on a future reality of spatial computing, automated labs, and efficient care that's patient-centered, what is the provocation to this group? What's the next step they should take, or what's the challenge that you throw out there?
I'll go first.
you keep handing it off.
Take it away.
No, listen, I'll take it. No, I think the provocation is, for you, I think that the challenge and the call for help and the cry for help is that you need to be the voice of this change that is happening, for sure, no matter what we do. And all of you, I don't know your backgrounds, but I would guess that most of you are in healthcare and or IT and tech and healthcare, and I think that it has to come from the base up. And I think that once the patients and the providers start crying for these changes to happen, they'll be adopted. And whatever you work, your administrators, your healthcare administrators, your regulators, they need to hear the voice of the end users of this, and we need to demand that this happens, because only then it will happen. The only way to accelerate this change is if the users, if the end users, if the ones who are going to benefit the most start really calling for help. And if you work as an administrator, you need to have a vision of how the future can be. And only you can do it, because if you don't, you're the la creme de la creme of telehealth, for example. If we don't be active ambassadors for this to happen, it will not happen as quickly as it will.
So build an awesome product that all the users want, and then.
Well, or don't be in a product. Just even if you're just a user, you call and you demand that this is used, and spread the voice with your patients and your administrators.
Be that opinion leader.
Yeah,
Robin.
That's a hard act to follow.
That's why I wanted to go first.
Touche. The only thing I would add is what we've learned today is that we need to change the educational system. Yeah. We need to revamp certainly the healthcare delivery to a home-based focus. We need to deal with the payers, and the government and get that ironed out. So I think, like I said, it couldn't get any worse than it is today, which is good news because we're getting ready to overhaul, but it will take the charge of the initiated and make this change happen.
Sure. So use the chaos to your advantage. There's a lot of energy in the broken system, and use that to catalyze.
A lot of
forward.
opportunities.
Yeah, a lot of opportunities. Well, I just want to thank both of you very much for your engagement. I didn't prepare them with any questions beforehand, so they jumped in even on the single payer one after a little warm up. So that was, just appreciate the candid conversation. I appreciate the audience's participation.
Thank you.
And thank you very much, both of you, very much.
Yeah.
So.
Thank you, guys. Thank you.